now as well. So thank you very much for joining us today, Professor Jones. Thanks to everyone who's here in the room with us. We've got quite a few in the room with us today, and also anyone that's joining us live on Facebook as well. So unfortunately, at our Project 9090 launch yesterday, Professor Jones wasn't able to join us. And I don't know if anyone can close enough to see his name on screen today, but it's Hop Along Jones.
So there's my
last few weeks.
There's the fracture boot on my foot.
So you weren't able to,
right?
So we really
So I'm
missed you.
sitting here with a broken leg.
You weren't able to travel, but very kindly still offered to join us for our Q&A session today, which is brilliant.
Indeed.
So what we thought we would do for the first part of today is, for anyone who wasn't able to join us in person yesterday in Edinburgh as well, is just if you could give us a bit of an overview about Project 9090, what we're hoping to achieve, and I can also talk a little bit about how as patients we can contribute to that as well.
Yeah. Okay. So very sorry for not being there, but it's a very important initiative, and it sort of came out from one of the meetings actually that the foundation had, and we were talking about things, and it's really about in medicine we spend a lot of time trying to develop ways of doing things, okay? And the problem then is, once you've got ways you can do things, you actually have to make sure you do them, because having them isn't enough if you don't use them, okay? And this all came out of a national audit that was done in the UK, but my colleagues in America and in Europe tell me that it's exactly the same in their countries. Absolutely the same, that basically we do not do the things as doctors that we know we should do, and we know we should do them because they're in the guidelines that are there for people to see. And it's a fascinating question, why do people not? And what I'm talking about is things like using URSO at the right dose, going on to second line therapy, asking about symptoms, and then where people are developing complications, having their case being discussed with a transplant unit and themselves at the right time to move through the system, okay? And those are the basics of PBC, and we know now what to do in each of those situations. But when you do an audit, and in fact they looked at the records of 9,000 people, it's a huge exercise. My colleagues did it across the country, and I'm very impressed by it. It shows that we're not good at it. 50% of people only were being asked about symptoms. 40% of people who might benefit from a liver transplant were not being discussed with a transplant unit. And it's not good enough, basically, and what we need to do. And of course, we're in a world now where we're developing, more, elafibranor and seladelpar are all steps forward, acetylgallic acid we've talked about, and all of those, bezafibrate, all these options. But if people are not getting a second line treatment, having 4 options isn't going to make any difference, because they're not going to get any of them. It makes it worse. So Project 9090 came from something that Gideon Hirschfield, who many of you will have come across, and myself came up with around the guidelines, which is we need to set a standard that people can aim for. All doctors do audits, part of our training. You're supposed to look at your practice critically. And all junior doctors in training have to do an audit, but they always tend to do the same things. And to do an audit, you have to have a standard to be measured against. So how effective are you compared to what is an expected or reasonable thing? And it occurred to us there were no audit standards in PBC. So nobody did audits in PBC because there was nothing to compare it against. What's good, what's bad, what's in bad. And so we came up with a whole series of criteria for good quality PBC care that 90% of people should have, okay? And it was slightly on the back of an envelope, but it seemed reasonable. 9 out of 10 people getting it sounds good. And not everybody is going to get all of those things. So we decided that perhaps if 90% of people got 90% of the care that is correct in PBC, we would be vastly better off than if we invented 5 new drugs, okay? So Project 9090 is the concept that we must push and push and push and push until 90% of patients are getting 90% of the care standards that everyone accepts that are out there. So that's it, 90% of people getting 90% of the things. Now, yesterday, and why I'm sorry not to be there, is that I actually had some data and Robert presented it, and I presume he was very rude about me and passed some appropriate jokes. I knew he would be.
I was actually tempted to ask you to run through your presentation so I could compare it and give you both a score, but I decided not to.
So what I put into that is something really important. So around the UK, after the audit, a group of people developed what's called a care bundle. Now, care bundles are something that are familiar in the NHS. So it's a standard NHS tool. So if you go into an A&E department, having broken your leg, that's very topical, and you've got heart failure, there will be a care bundle to manage heart failure. And that means that the orthopedic surgeons managing your broken leg will know how to manage heart failure, even though they're not heart failure doctors, because it's a simple series of instructions. Mm-hmm. And there've been a whole series of these which have actually really improved outcomes for people with other health problems going into A&E for a different reason. Okay, and there was a care bundle in cirrhosis, so that if you went in after a road traffic accident and you had cirrhosis, often people were dying of the complications of cirrhosis because their liver disease was made worse by the things that were done managing their other problems. So you can't ignore the fact that somebody's got cirrhosis. You have to do it. And some colleagues of mine in Newcastle actually developed this, and it made a huge, it's adopted around the NHS. It's standard practice, a simple set of documents. You can pull it out and it tells you what to do to not make the cirrhosis worse. Okay, so it's a simple script for non-experts. So we had the idea, what about a care bundle for PBC? This is not for me or for Birmingham or for the Royal Free or for King's or for the centres that do a lot of this. It's for the places that don't. And it's a simple guide, and it's a front and back sheet, and it just takes the guidelines we used. Back sheet is simple instructions, front sheet is a tick list of all the various different things. And they took this, developed it, and they piloted it in 12 hospitals. Okay.
I'll just say that care bundle was in a recent edition of the Bare Facts, so it is available on the website for anyone who wants to look at it. I'll pop a little link in.
So they piloted it in 12 hospitals, okay, and it was something like 10, and they did the audit before and after in those centres, okay. Mm-hmm. They looked at audit performance before and afterwards, and the audit standard was 90%. And after the care bundle was implemented, they were meeting 90% of those care standards fully. That's 90%. So this care bundle, simple one-page document, guidance on the back, checklist on the front, actually led centres, all of whom were failing before in terms of the criteria, to be 90/90 compliant. Okay, and that matters because it shows we can do it. It's not impossible, it's possible. Okay, now the problem with that is that those will be hospitals interested enough to do this. So they're interested enough, cared enough. They weren't perfect by any means, but they had the desire to be better. And when they did this, they were better. And so, can Project 9090 succeed? We've shown it can. And what we now need to do is to roll it out and to work out what the best way to do it. So Project 9090 is our mission, that 90% of people get 90% of perfect management in PBC. And after that, it would be Project 95/95, because 90 is okay, but it's not perfect. What we find is that with improvements in care, it becomes a virtuous circle. So what you get is that organizations don't know what they don't know, but once they start to get it, then they start to improve. So this becomes self-sustaining after a while. And if you're doing it in 90% of people, basically you're going to do it 100% of people. So it becomes virtuous circle. So that's what Project 9090 is. It is simply a way of helping people to do it right, because I have a positive view of human nature. I do not believe that any of the doctors and nurses not doing it properly wakes up in the morning wanting to do it wrong. It's just that they don't know enough about how to do it right. So we want to help them with it. So that's what this is. And that care bundle data is really important because it shows it can be done.
So in addition to the care bundle, I spoke a little bit yesterday about the new resources that we put together for PBC Day this year, which was last month. So we have some new documents to help us as patients contribute to that. So we've got our patient guide to clinical guidelines so that we can understand that in a bit more detail in terms of it sort of sits alongside the care bundle from a patient perspective. And then we've also got a document that helps us prepare for clinic appointments. Because certainly I know what I'm like, I plan in advance, I think about the questions I'm going to ask, and then when I'm in there, I forget about it. So it's just about preparing for your appointment, making a note of the things that you want to ask about. If there's anything you're not sure that you've had that you should have, then that's the opportunity to ask about.
And I think that's so important, because it's very difficult for doctors to duck an issue if you specifically raise it. Okay. So if you go and say, how am I doing, doctor? Then the doctor will say, fine. Now, that could be because they've reviewed your biochemistry, which is normal, your FibroScan, which is 5, and they've seen your symptom severity scores, all of which indicate it's mild or no symptoms. Your bone density is fine on DEXA scan, which indicates you're fine. Or it could be that's just what they say, okay? And you don't know the difference. Obviously, if you come and see me, you know what it's going to be. If you say, am I an URSO responder or a non-responder? Okay, that's a very specific question to which the answer is going to be yes or no. And you're going to remember what that answer is. So if you turned out not to be an URSO responder and they said you were, they're going to get into trouble for that. So a very specific question is very difficult to duck it. Of course, once they say you're an URSO non-responder, then of course the next question, which is what you're going to do about it, what are my options to do about that, becomes very easy. So we have a saying in medicine that the better the question, the better the answer. And so for example, if you're doing, I know we don't normally talk about such things, but I'll say it very quietly, liver biopsy. So when you do a liver biopsy, you don't send it off to the pathologist to say, here's a liver biopsy, what do you think? You say, here's somebody who's AMA positive, but has a high ALT with a high IgG, raising the possibility of PBC AIH overlap. Would this patient benefit from a trial of steroids, do you think? Right? Now, if you just say, what do you think's going on? They'll say it's PBC with some inflammation. And you're going to read that and you say, but I knew that already. That doesn't help me. But that other one will give you a specific answer to a specific question. Okay? So that's why I'm sorry for mentioning liver biopsy. If Robert was here, he'd send me to purgatory at that point. Okay, but ask a particular question and then follow up the particular answer. And it also says that you kind of know what you're talking about. One of the things that I find very interesting is it's very obvious to me when somebody I see as a patient is a clinician, a doctor or a nurse, or has a family member who is a clinician, a doctor or a nurse, because they ask a certain type of question in a certain way. And that's why I always want to know if I'm looking after somebody who is a doctor or a nurse or is speaking to them, because I know that they're going to have things that have been discussed with them, and you up the information level. But it's very obvious if somebody's asking informed questions. So keep your doctor or nurse on their toes. That's what I would say.
And that's the importance of us as patients being informed, isn't it? Yeah. Getting the correct information and up-to-date information and being prepared for your appointments. And we're absolutely here to help patients with that as well. If someone has an appointment coming up that they're a bit worried might get complicated, please just reach out to us.
And be under no illusion, the more informed a patient is that I see, the happier I am, because we can have a much higher value conversation. You know, if people are aware of the basics and have got specific questions about themselves, then we can have a really specific conversation about it. So it's very good for everybody.
Dr. Yeoman talked about yesterday about the patient and clinician partnership, which was really good.
Exactly.
Around what you're saying there, us being informed and being able to have using our time at clinic as optimal as possible to discuss what we want to discuss. So it was an excellent event, and we were really excited to get the launch open.
And I think maybe so something for the the app down the line is actually building in the ability to track FibroScan, because do you have that at the moment?
Not FibroScan, no. That is something that we're looking at in the new version of the app.
Yeah, so you track it all. And I have to say, I saw a very nice lady for the first time who came along and brought her FibroScan value from the conference.
Very cool.
And and again, having blood tests done already, and it means it's very valuable. So just having those numbers to hand, when you go and see the clinician, just means that I'm not being critical of clinicians, but just keep them on their toes.
Mm-hmm.
Unlike me, I'm not on my toes at the moment.
Not at the moment, you're not, no. We had, over the weekend of the patient conference, I think we had about 80 patients, 80 people who were FibroScanned, which was just amazing, because sometimes people are waiting a bit longer for those in certain areas, and they were able to.
Yeah, we're very aware of it. I mean, we're very lucky. We have it in our clinic, so people pop next door, get it done whilst there and then, which is how it should be used, actually.
So that was great. We did manage to record some of the sessions from yesterday. We're just going to edit them and see what we can do. And then
did you record Robert doing my?
I did, yes. I'll send it to you for scoring. Yeah. It can be like Strictly. I'll send you it for scoring.
I personally, I'd vote Robert into the dance-off any day. I've literally never watched Strictly.
See him dance again, though. That's just so we can see him dance again.
There you go.
Right.
Apologies again.
No. We did really miss you, but it was really good to see all the things we've been talking about, things that have been discussed at the summit as well. The work we've done with the other patient organisations around the world to see this, because we are hoping this will be a truly international campaign as well.
And I have a mantra that people will have heard who've heard me talk before, that the secret to PBC management is simple things done well every time. Okay, simple things done well every time. If you do the bloods and look at them and act on them, do a FibroScan, look at it, act on it, ask about symptoms. Ask yourself, does this person need to be discussed with the transplant unit? No, for 99% of people. But if you ask every time, has this person had a DEXA scan? Are they at fracture risk? And it takes a nanosecond to do that. That's my mental checklist. I go through that with every patient, every time. And if everyone did that and then acted on the results, we wouldn't have a problem anymore.
And that's what the care bundle is in simple terms. It's just it's that list, isn't it?
And the reason we use that terminology is a standard terminology, and NHS doctors are familiar with it. So it won't necessarily translate into other countries where they're not used to that concept. But this is why I hadn't quite realised, is that the moment you say, here's a care bundle, people go, oh, it's the care bundle. And it's not some guidance we've come up with or a guideline or suggestions from the PBC Foundation or whatever. It's NHS speak, and therefore it's official, it's been adopted by the NHS, therefore people will go for it. And that's the bit I hadn't quite realised. That's why it's worked. It's because it's what you do.
Yeah.
There you go.
It was great. Thank you for that. So just before we go on and do some general questions, I'd like to say that our Q&A sessions continue to be as popular as ever, and we do have quite a backlog of questions. So if I don't get to your question today, please know that it is still on the list and we will get to it. And remember as well, just before we start, a disclaimer that these Q&As don't take the place of a consultation with your own clinician. We're aiming to provide general medical information and not medical advice.
I thought having done lots of these would indicate nobody wanted to watch them anymore. There'd be no more questions. So that's reassured me a little bit.
Yeah, we have, and it does continue to be. I touched on it yesterday as well, that they are still as popular as ever. And actually, we've got a couple of questions that are first up today are about elafibranor. So I think it just shows that patients are aware of what's coming and questions are changing with the dynamic, which is great.
So elafibranor was approved by the MHRA 2 days ago. So it's now MHRA approved, so it's licensed in the UK. That's not a great surprise, but it's been assessed by NICE, and their decision was only waiting. Obviously, NICE can't recommend a treatment that's not MHRA approved, so I suspect it will be available in the NHS within a small number of weeks.
That's one of the questions about when will it be adopted by NICE. That was one of the questions. When will it be adopted by NICE?
Yeah, so the NICE discussion, I was involved in it. The NICE discussion has happened. Um, it was a very positive discussion, and they simply spiked the decision until it was approved. Okay, because one will follow the other. So we suspect what will happen is it will just be adopted alongside obeticholic acid as a second option, discussed and used in the same way. I'm going to do something which perhaps surprises people. I'm going to defend NICE here. And again, this is for people in the UK. So NICE is the body that decides not whether drugs are licensed, that's the MHRA or the FDA or the EMA, but whether they are cost effective enough for the state healthcare system to pay for them. So there's an important distinction there, which is a treatment might work, but if it costs £1 million a dose and the benefit is minor, you can't justify that, for a state-funded healthcare system, because there's a common sense element to it. So that's what NICE does. And NICE approval means that things have to be made available. So this is important when we've talked about doctors not giving second-line therapy. Obeticholic acid was NICE approved for the use in PBC patients. So a doctor not doing it was actually not about following NICE guidance, which it can get you into trouble. So it's not kind of nice for you to think about, no pun intended. It's a good thing for you to think about. It is actually mandated. So NICE will, I've no doubt, I've no inside knowledge, but I would be astonished based on what's happened before in the discussion that they'll approve it. What they want to know, and when I go and talk with NICE, they want to know what's the problem here, why does it matter, what does this drug do compared to other things, and they want to make sure it's not just me saying it because I'm saying it, and they really want to understand what is the problem that is solved by the availability of this drug. Okay, and I've always found they've asked very good questions, and I hope I've given very good answers, but no drug I've ever been involved in any discussion with NICE over has been turned down. And the reason is you go into that knowing what you're talking about, to have a conversation with people who also know what they're talking about. And I think sometimes where drugs are turned down, it's because people haven't got the facts and they haven't prepared properly, and they've relied on an emotive argument rather than a rational and evidence-based one. So all my engagements with them have been tough but fair, and all of the decisions have been appropriate in my view. But I've always, like I do with everything, it may seem odd seeing this ramble today, but I do prepare for things, and you are ready, and you are, you understand what the things are. So NICE is a very good body, and it's very helpful for drugs to be NICE approved, because that is your argument. And if you really want to scare your doctor, you could say, but I thought second-line treatment therapy for PBC was NICE mandated. And then that would usually have the effect, because it is no. So after obeticholic acid was approved, I got a letter from the chief executive of my medical director of my trust to say, here's new NICE guidance mandating obeticholic acid second line therapy of PBC. Can you reassure us that you have a system in place to ensure that patients access this? Well, given we'd invented the system, the answer was yes. But actually, every hospital will have had that letter. So it's not optional, okay? And it's important for us all to remember that. We sometimes are too deferential to the NHS. Oh, would you mind terribly thinking about this? No, it's mandated. It's mandatory. You don't have a choice. And any doctor who says, oh, these treatments are too expensive, we should be using something cheaper, that's what NICE is for. NICE approval is to decide whether something is both effective and cost effective. So it is this effective enough to go into the NHS, and is the cost that the drug is charged for the drug appropriate for the benefit? I'm not a health economist, but NICE are, and if they say it meets that criteria, it is not for a doctor to make a secondary judgment about that. That's why we have NICE, okay?
And NICE also take into consideration the patient voice as well. They
Very
have
much so. Very much
patient organisations, and patients were heard at that as well, which is great,
Very much so. But it is, no doctor should turn, we get this as bezafibrate, there are reasons to use bezafibrate, but not just because it's cheap, because the approved drugs have been NICE approved on the basis of the balance of effectiveness and cost. That is not, no individual doctor can overrule the view of NICE, and that should be quite foolish too when you don't know any health economics.
Yeah. So I'm just going to go over that first question we've covered, which was have we any idea when elafibranor will be adopted by NICE in the near future? But there was a question that had a bit more detail. So a patient who had listened to you previously and had heard you talking about elafibranor, they're a non or a partial responder to URSO, and they started on bezafibrate 3 months ago, which has brought the numbers in line, but knocked their kidney function slightly out.
Yeah.
They asked about elafibranor and was told if bezafibrate works, then that's all they need. Could you tell us a bit more about elafibranor?
Just before I answer that very good question, there are a couple of questions about FibroScan coming in the chat that I'd be useful to pick up because they're very helpful. Okay, so we'll pick those up. Right. So elafibranor is now a licensed drug, and it is licensed for use in PBC patients, in people who are under responsive to UDCA or who can't tolerate UDCA. And under responsive to UDCA in the UK does not have a number definition. That is for the clinician's judgment. That's very important. So we talk about 1.67 times the upper limit of normal and 1.5 times the upper. In fact, the criteria for the drug do not include that. It is my decision whether somebody, and of course the reason for that is that you need to factor in other things, age, for example. So, you know, an ALK phos that's very slightly elevated when you're 80 isn't going to cause you any problems over a meaningful amount of time. But if you're 20, that's a different matter, right? So you have to have some common sense. To be a licensed drug, it has to be safe and it has to be effective. And its effectiveness in clinical trials, but also its safety. And so this whole licensing process came about because of thalidomide, people will be familiar with, but also Oprin and celecoxib and some of these other things. So it's very well worked out, and it gives an assurance about safety and effectiveness. Okay, and then afterwards we have a thing called the yellow card system, where anyone can report if they feel that they've had a side effect from their drug. Doctors can report it, patients can report it, and that's collected into a national database. That's called post-marketing surveillance, and that's to see if there any signal that's infrequent, but there when you've given it to thousands of people. So it's a tried and tested system, so that this drug has been approved for use in this disease because it's effective in this disease and it is safe. Okay, now bezafibrate, so obeticholic acid is licensed, elafibranor is licensed on those criteria, and seladelpar is licensed in America and will be licensed in the UK very shortly, I have no doubt. Okay, and that gives you that reassurance. Now, bezafibrate has been licensed in the UK, but not for use in PBC. Okay, it is licensed for use to reduce cholesterol. Now, does that matter? Well, yes, because the side effects that happen in liver disease patients happen in liver disease patients, and so it's not been trialed in its target population. Okay, and so it is not assessed to anywhere near the same degree in terms of safety, and it's also not been properly assessed in terms of its effectiveness. So the point being is that, I mean, I spend a lot of my time on doing and overseeing these trials. And what's it called? A regulatory trial, the trial that the FDA, the EMA or MHRA wants to see to get a drug approved, is done to a very high level, very nitpicky indeed. And bezafibrate has one trial done by academics with some flaws in it. So it doesn't have anywhere near the same evidence, okay? But it seems to lower people's blood tests, okay? But it's question mark about safety. Now, all drugs have side effects. Obeticholic acid causes itch. People are familiar with that, but that's a manageable thing. We understand it and deal with it. Bezafibrate does two things. One is it causes muscle pain. So people are very aware of the muscle aches you get with statins. Well, you get those with bezafibrate as well. That may or may not be an issue, but it also causes kidney problems. It can damage kidney function. And of the people who've had fibrates in Newcastle, 10% of people, 10% have had kidney problems. Now has not been picked up in trials because they haven't done the trials, right? That's why you do trials. Now, we do use bezafibrate, or we did use bezafibrate, for the simple reason that it reduced itch rather than causing it. So somebody with really bad itch who needed second-line therapy, it was very reasonable to use bezafibrate as an alternative, but with the caveat about renal function. Now, if I had a patient on bezafibrate who developed worsening renal measurable change in their renal function, I would absolutely stop that immediately. Okay. There is no reason to continue with it. And it's particularly the slow release 400 milligrams once a day version that does it. But when you get kidney problems, we would stop people. I can't comment for other doctors, but I've never been sued in my life, and I've never had a complaint made about me in my life. And the reason for that is that I'm very honest. I know what I'm talking about, and I don't talk about things I don't know anything about. And I'm very, very straight with people, and I try and explain things in the way that people will find understandable. And you know that from these things. So I'm very straight with people. I give people all the information, but in a way they can understand, they can ask questions. So I'm very straightforward about it. And I think you've got to be straight in what you do. And I think I'm very happy using bezafibrate, but I'd be very uncomfortable. So I don't practice defensive medicine, but I practice sensible medicine. Now, if you had somebody in the old days who got renal problems with bezafibrate and got itch with obeticholic acid, you're caught sight between a rock and a hard place. But what I would tend to do in that situation is use obeticholic acid with itch controlling medications, okay? Because itch is less of an issue to me than kidney things that can ultimately result in kidney failure, if you don't pick up on it. And I think where you've got a drug side effect causing organ damage, you kind of need to stop it, because and that's difficult to defend if you don't do that, because you kind of know there's a problem. If I warned somebody that they get kidney problems with bezafibrate, they went away and they got kidney problems, that you can't predict it. But if they got kidney problems and nothing about it, then that's my problem. It's self-evident. Now, where do I think bezafibrate sits in 2024 now that elafibranor is approved? Elafibranor is a good drug. Okay, we've got trial experience. We're starting to use it in specific. We can now get access to it. Our first people are using it in the NHS in an early access program. So it really adds something. To me, there is no, and elafibranor does not cause kidney problems. Okay, full stop. With the caveat, we need to see it for years in practice. Knowing what we know now, it does not. And the reason we know that is because we've looked at it closely, because it's an obvious question and an important question. So to me, in 2024, there is no reason to use bezafibrate. Elafibranor is a more effective, safer, better evaluated version of bezafibrate. And on that basis, you should use, if you want to use that type of drug, you should use elafibranor, full stop. If you've had side effects from bezafibrate, I would certainly use elafibranor in our practice, and you weren't going to go down the obeticholic acid line. I would certainly use elafibranor, and I think that's going to be an important thing. Why not use elafibranor? Well, it's not technically available at the moment, so but if it, in a few weeks' time when it is available, then there is no reason to stay on bezafibrate and got renal impairment. You need to go on to either obeticholic acid or elafibranor, and which of those you go down would largely depend on the itch. And I do not think there is any reason to stay on bezafibrate. Okay, two things to say about it. The first is that the reason why doctors use bezafibrate is cost. Okay. But remember what I said about NICE and health economics? That's what NICE is there to decide. So I'm not sure what a doctor who wants to use bezafibrate because it's cheaper knows more about the cost effectiveness of drugs than NICE does. And also, I do the best I can for my patients always. I don't do the cheapest I can for my patients. If the best is the cheapest, so much the better. But this sort of sense that we have to cut corners for our NHS, I don't buy into at all. because we use very expensive cancer drugs and we use very expensive antiviral drugs. And I don't see why PBC patients are less valuable than cancer patients or viral hepatitis patients. I really don't. And I think we have had a revolution in treatments that are safe and effective. And it seems to me a little bit strange to do them. The other caveat is what would I do if I was stably on bezafibrate with no side effects and normal liver blood tests?
Yeah.
Well, I would stay on it. Okay. I wouldn't go changing just for the sake of it. So you change for a reason. So we've still got lots of people on fibrate, lots of people on fenofibrate, which we used before bezafibrate. Why have we not swapped them? Why would I swap somebody who's got good symptom control, no side effects, and normal blood tests? I mean, what are we going to gain from that? And all doctors will tell you there's an element of, you change something and what happens is, you lose control, and just don't fiddle. So elafibranor, important additional options for therapy are very important. Elafibranor is a good drug, properly evaluated, safe and effective in PBC. Who should get OCA? Who should get elafibranor? That's for down the line for us to work out, but it's good to have options. And the swing thing is around the itch. But bezafibrate is the agent we need to question more, because somebody who continues with bezafibrate, a doctor who continues bezafibrate in the light of renal dysfunction is asking for trouble.
Okay. Just before we move on to those questions you mentioned in the room here, there's another one about second line therapy. We've got a patient who was diagnosed in 2020, been on Arso, but alk phos hasn't dropped below 150 and now back up to 250. So they recently started OCA. They're getting some side effects, bloating, dizziness, sore throat, and asking when will these calm down, and also how often should they be getting followed up after they start OCA for the first time? Okay.
There's something I forgot to say, and this is going to sound like a shameless plug. So here comes a shameless plug. But the third edition of my book is emerging in not too long a period of time. And if it sounds like I've gone through these arguments about when to use elafibranor, when to use seladelpar, when to use bezafibrate, that's because I go into this in a lot of detail, because I never intended to keep writing different editions of it, but these are going to be such live questions, and nobody knows.
Which is amazing. Things have changed. Things are moving on and changing.
So it's going to be entirely updated to cover these questions about what it all means as we move forward. And on my website, I've got an updatable thing as to which drug is licensed in which country at what time, which is also quite useful for people. So this needs to be explained. We'll cover it in the better facts as well, because these are super live questions. That's okay. So side effects of obeticholic acid. So the itch we talked about. The other one is in people with more advanced disease. All of these drugs can make your liver disease worse. So there's a point of severity beyond which you don't want to use any of them. And these drugs are no different to each other. So it's not one drug versus the other. This is why you need to treat people nice and early, so that they're going to get the benefits without any of the downside. So those are the kind of well-known side effects. Now, all drugs have, other more niggly side effects. So GI disturbance, because obeticholic acid is a bile acid, it can cause some nausea in people, like urso can do. So we see that. Interestingly, throat pain came out in the trials. Nobody quite understood why it was happening. Maybe it was a bit of reflux or something. So that's certainly something we came across. So these are what you call niggly side effects, and they can grind people down after a while. They would usually start to settle down after 2 to 3 months. And if they're not at that point, you want to think about a treatment change. Now, in the past, where you had fewer options, that became more difficult. So that will be an argument to think about bezafibrate, but it has its own problems. The advent of elafibranor seladelpar means that we now have options. And so, rather like with blood pressure tablets, if you have one that doesn't agree with somebody, you've got lots of other options you can try. And that's why this will work really well, is because just having different things to try means that you can find. And what you're looking for is something that agrees with you and works with you, that you're comfortable to take over a long period of time. And so I think that's where those things. Now, elafibranor, seladelpar are not going to be the panacea. They're not going to be the drugs that have no side effects. That drug has never been invented. But what they'll have is different problems. It's a little bit like, for people with autoimmune hepatitis or post-transplant, you've got azathioprine. Some people get side effects of azathioprine, but we've got MMF, and MMF has its own side effects, but they're just the different ones to azathioprine. So, if you can't tolerate one, you take the other, and actually, in my experience, one of them is usually fine for people. So it's a bit like that. How do you check up on people? We would start people on obeticholic acid, and we would speak to them in 3 months and then see them at 6 months. And whether we did some bloods before 6 months would depend. It's actually a phone call at 3 months just to see how you're getting on, any problems with it. And people can contact us if they are having any problems before that. But we don't tend to, as we're more familiar with it. I think when we start elafibranor, I suspect we'll see people earlier, just because once you've treated a couple of hundred people with a drug, you understand it. And I think with a newer drug, just that's not any concern or fear about the drug. It's just that I want to get a feel for it. I want to know what people are telling me in the real world with it. So I think it will be, but eventually it'll settle down to three months. Elafibranor, you don't increase the dose; it's a fixed dose. So unlike obeticholic acid, where you look to increase the dose after a few months, so it's a sort of single drug. You then just take it. Okay, and so it looks pretty simple to use.
Just another thing on OCA, we did have a patient who'd asked about reading. She'd obviously been looking at the potential side effects, and the leaflet mentioned potential liver damage, and you touched on that earlier on. So, yep. I mean, that's something that's obviously needs to be monitored if someone does start OCA, which we're just talking about monitoring up here. Yeah.
PBC, there are two sorts of PBC, basically, in many ways. One is people with advanced cirrhosis with complications, and then the other is everybody else. Okay, so the split in PBC is 99-1, pretty much. Okay, so I'll give you an example of what I mean by that. Is pregnancy safe in PBC? Okay, it is risky in people with advanced cirrhosis and decompensation features, and you need to monitor it and do endoscopies and things like that. And the other 99% is absolutely fine. Okay. And it's very like that with obeticholic acid, is that in those people with advanced cirrhosis and complications, by that we mean jaundice or ascites or varices, then obeticholic acid can make the liver worse. Okay. But that is because the liver is on a knife edge, and any change to the environment can tip it over. That's the same as any drug in any liver disease can do that. Immunosuppression in autoimmune hepatitis can do it. Antivirals in hep C can do it. Stopping drinking with alcoholic liver disease can do it. So it's about destabilizing a situation that's on the knife edge for stability. And if you're not in that group, which is the 99%, then it doesn't cause liver injury. So it does not make anybody, in my experience, with early PBC worse ever. Okay, it improves people to whatever degree it improves, but it is not hepatotoxic. Bezafibrate actually is. The bezafibrate will make a small number of people actually worse with early PBC, although most people will be better. Elafibranor or seladelpar don't appear to make people worse. So it's like all drug information leaflets, is they talk about everything that could happen, scare people to death. But the reality is it's a much more nuanced risk thing. But do not be worried about liver injury in somebody without cirrhosis, full stop. It's very safe in those settings. Itch is a different matter. It's much more unpredictable.
Okay. So we'll take the question about the FibroScan here. We've got a couple here. So how often should you have a FibroScan? What does the IQR% mean? And this patient has a reading of 5.4 kPa and 8%.
Okay. And are all people suitable for FibroScans? Okay.
Yeah, that's the next one after that. Yeah.
All right. Good. So they're three good questions. So where we are today in 2024, there's very good work from Christophe Corpechot, who's a name very familiar to lots of people, from Paris, done a lot of work on how does FibroScan fit into it. And what he's shown is that the optimal way to monitor PBC is blood tests and FibroScan. Okay, and the combination tells you almost everything you need to know. And the reason why both are useful is because, as I often say, FibroScan is slightly backward looking. It's telling you what's happened in the past, how much injury has happened because of what's happened in the past. And blood tests are forward looking. They're talking about how much injury will happen because of what's happening now. And so they look at different things. So you can have people with a bad FibroScan but good bloods because the disease has been bad in the past and is now treated. You can have people with bad bloods and a good FibroScan because the disease has just developed and is very active. So that's why both are useful. So it tells you where you are and where you're going. All right. So FibroScan is in an ideal world, you would do it every 1 to 3 years. Okay.
Mm-hmm.
And the reason you do it variably is it depends what the first one shows. So if your FibroScan is normal, there is no point in repeating it in a year, because even if the disease was rip-roaring, it wouldn't particularly change over a year. So if it's very mild, we do it every 3 years. And it's also important not to overdo it, because you will get occasional rogue results. Anybody who does these tests, or looks at these tests, you will occasionally get a day when you get a FibroScan value that just doesn't make any sense. And, no matter how good the person doing it is, you'll get a rogue result. And one of the things that's important about FibroScan is that it is only ever part of the answer. It's never the answer. It's part of the answer. And, what we spend a lot of time teaching clinicians is that you need to look at it in the round. So look at the whole story. Does this make sense? If it doesn't quite make sense, repeat it on a different day with a different person, So, there's an element of common sense to it. Don't slavishly believe it must be right, because and of course it has a decimal point. That makes it sound very accurate, doesn't it? So it's 5.4 as opposed to 5.3 or 5.5. But it is a human observation, and it's susceptible to observer error. So it's kind of an important piece of information. 1 to 3 years. And if your FibroScan is 10, then that's the level you get it every year, because that's in that tipping point. We think 10 is about the point where it's starting to get a little bit more concerning. It's not cirrhosis, but there's clearly fibrosis there, and we want to be on our top game. We want to have as complete control as possible as soon as possible, and that means regular follow-ups. And this is where the question of what is acceptable liver blood tests come into it, because in somebody with a FibroScan of 10, for example, any abnormality in the blood test to me is too much, and so therefore you want to treat it. So that's the place where things are not as good as you'd like them to be, and you can make a difference. FibroScan above 20, there isn't much point repeating it because it's cirrhosis, and it's not really going to change. So the frequency depends on where in the range people are. You'll get a number, you'll get a KPA number, and you'll get an IQR, okay? So the KPA range is the number. That is how dense is your liver, and that will range from about 4 to 60, okay? Once it goes above 15, it rises very rapidly, and that's the point at which somebody is cirrhotic. And it rises very rapidly because it gets more solid very rapidly. But 95% of PBC patients are below that. Below 4 doesn't exist because your liver has a physical structure to it. So 4 to 6 is completely normal. If you stop people in the street and did a FibroScan who had no liver disease, that's the values they would get. So the person who put in there 5.4, brilliant, that's normal, okay? And so that doesn't need repeating for 3 years. That's very, very reassuring. But of course, you want your liver blood test to be normal, because remember, that's looking at a different thing. The IQR is the interquartile range, and that is the accuracy of it. So if somebody does multiple, anyone's had a FibroScan will know they do multiple pings, right? And they record all their values. And they'd like all those values to be the same, except they won't be, because you'll move around and the person doing it will move around. And what you're looking at is the variability of it. So how reproducible is it? And the more reproducible it is, the more you believe that number, okay? So if it's 5.4 with an interquartile range of 8%, that's very accurate. So there's less than an 8% variation between all the different values. So it goes from, 5.9 to 4.9, basically, doesn't it, if you think about it? So it doesn't matter which of the values they look at, they're all normal. So that's very good. If that was 80%, that implies that there's actually quite a big variation. And that's you just need to be a bit more cautious about the value. So it's the confidence with which you look at that number on that day as being an accurate representation of what you're doing. Are all people suitable for FibroScans? Yes. Yes, they are more straightforward in some people than in other people. So those people who are, shall we say, carrying a little bit more timber, like myself, it's more difficult to get reading. So what you often find is the interquartile range is slightly bigger in those situations. A lot of muscle. I'll credit myself with a lot of muscle, shall I? Yes, I think so. So the more that has to go through before it reaches the liver, the more inaccurate it will be. But remember, fatty liver is assessed using FibroScan, so it works very well. There has been a real improvement in the technology. So FibroScan is not now the same as it was 10 years ago. Like all of these things, the technology has improved, the scanners have improved, the sensors they use have improved. So basically, you can FibroScan everybody.
Great.
Okay? But the IQR gives you some sense of how confident you are in the value. The number's still the number, but it's the extent to which you'd bet your life on the number. IQR of 8%, you'd bet your life on it. IQR of 80%, yeah.
Okay. I'm just going to ask that actually, which end of the percentage is a good one and which is bad?
Yeah.
In terms of, so there's another question, and it was one that came in earlier.
Sorry, for both IQR and FibroScan, lower is better.
Lower is better. Good.
Okay.
So we've got a question about bilirubin. So what is a normal and high level, and why is it important in the measurement of a measurement? Why is it an important measurement in PBC management?
All right. So bilirubin is the opposite to FibroScan values and IQRs and ALPHOS for that. It's the same. It's lower is better. Albumin is the one that is the opposite one, where higher is better because that's made. So bilirubin is the breakdown product of red cells. So your red cells last 150 days before they become tired and they need to be disposed of. The body recycles them. It rips out the iron to reuse it. But the rest of the bit that the iron sits in can't be reused. It's the only bit of a red cell that can't be recycled. So the body has to get rid of it. And basically, it converts it into bilirubin. That gets carried to the liver. Liver kicks it out into the bile, so makes your bile green, and your body gets rid of it. So that's the normal pathway for bilirubin. Okay. In a condition like PBC, because the bile isn't flowing normally, the bilirubin can't get out into the bile sometimes as effectively. And so if the liver is affected, above a certain degree, the level will go up. Okay. And so that makes it quite a useful measurement, because if your bilirubin is normal, it indicates that aspect of liver function is normal. Okay, so you can't have a normal bilirubin unless the liver is kicking out bilirubin normally. Okay, so it gives us some important information. Now remember that if your bilirubin goes up, it doesn't have to be because of the PBC. So for example, if you're breaking more red blood cells down, you're producing more bilirubin because you're breaking red cells down, and that's got nothing to do with your liver. And given that autoimmune breakdown of red cells is associated with PBC, these things happen. So like everything, it is part of the story, not the story. Okay, so bilirubin goes up later in PBC. It goes up in people who are beginning to lose a lot of bile ducts, so that stops the bile flow, and it goes up where people are becoming cirrhotic because the liver can't. The liver isn't functioning well enough to get rid of the bilirubin. So the test going up is useful. In fact, in PBC, it more goes up because of bile duct problems. So bilirubin that's normal is a very important sign in PBC. Bilirubin that's starting to rise is a reason for us to take extra care and attention. The normal value, it depends on whether, as people always say, the USA and the UK are two people separated by a common language, and bilirubin is one of them. We use a scale where 20 is the upper limit normal. So normal is between 0 and 20. In America, it's 0 and 1 because they use different units. Okay, so just be aware of that. So in the UK, a bilirubin of 20 is normal. it is pretty clear that a rising bilirubin within the normal range is something to be aware of. So if it's always 10 and suddenly it becomes 20, that is significant, even though it still quotes normal, because the worry is what's going to happen next time around. So anything above 20 brackets 1 in the UK, close brackets, we would file away and want to watch more carefully. Okay. Now, I was taught when I was a lad many years ago by Oliver James, who was a great guru at PBC, you think about transplant at 50 and you do transplant at 100. Okay. And you know what? All those years ago, he was right. Those are exactly the right figures. So 50, if it's 2.5 times the upper limit normal, now is the time to start. You know, that's where we have the conversation. Have we heard about any treatments for PBC? Have you heard of any treatments for PBC? You know, have you heard about transplant? What do you think about it? That type of conversation. And 100 is time to get it done. So it is useful. It's not infallible, but a normal value is actually very reassuring with it. But remember, if it is elevated, there are actually lots of things that do it. But if it's normal, everything has to be normal. So that's why normal is more valuable. Normal tells you more than abnormal does. Abnormal tells you it could be one of several things. Normal tells you none of those things is applicable.
Yeah. We have another question in the chat here from a patient who weighs 80 kilograms and have been on 1,000 milligrams of urso for a year, considered a non-responder. Could this be due to underdosage, and would increasing to 1250 help?
Yeah, so there's evidence that urso, the difference between taking urso and not taking urso is very significant in terms of what happens to people. The difference between being on the right dose of urso and on not the right dose of urso, slightly too low a dose of urso, is measurable, but it's nowhere near the same as not being on urso. So all urso is beneficial, but you don't get the maximum value until you're on the correct dose. Yeah. So, and whether or not increasing the dose makes a difference, it all depends how far off the tests are. Okay. So if it's if 200 is the target you're looking for and it's 205, then actually it may well be that increasing the dose makes a difference. And certainly I would always look to increase the dose so that in a sense you are confident that you've been adequately treated with urso. If your alk phos is still 500, no, that's not going to do it. And so you're going to need second line therapy. So the devil is in the detail. In my experience, marginally upping the dose of urso doesn't make a big difference. I think it's marginal gains, but it's important to do it because you haven't technically failed urso if you've not been on the right dose. I'll answer a question that's not been asked, which is that if you have normal blood tests and are on too low a dose of urso, do you increase the dose of urso? No, definitely not. If it's working for you, it's working for you. All you get is more side effects, so there's no need to do that. So technically, yes, I would, but it depends on what you're asking it to do, because I think any gains are marginal.
We touched on that yesterday, actually, because some people who are on, not as part of the audit, so some people who are not on the correct dose of urso, but are responding well and doing good, then that's, something like that,
don't tell me about it. You know, when very good Jess Layton, who a number of you will know from various PBC Foundation things, she did the very first pilot order, and she came back horrified because only 50% of our people were on the right dose of urso. Okay, and she said, "But this is terrible." And I said, "Split that into those who were full responders and those who weren't." Okay, and when she did that, 90% of people, 90% of people were on the correct dose if they were non-responders. But of the people who were responders, many of them were on, quotes, too low a dose. So I said, but that's fine. We're asking the wrong question. Is that we should be asking what percentage of people being started on urso are on the correct dose, because that should be everybody. But why would you, if somebody's had normal liver blood tests for 20 years on 600 milligrams of urso, it used to be a dose we used all the time, why would you increase it? I mean, so like all of these things, across 1,000 people, on average, yes, the correct dose is better. But you as an individual it is you. It's what's called an N=1 trial. And if you've responded to a particular dose, that's the right dose for you. Simple as that.
Great, thank you. That's
I am going to have to drop off because my next call has called in. But
no problem. No problem. I'm just going to finish
question?
up anyway.
What was the question you're going to get to next? Was that one?
That was the one that we just covered.
Oh,
yeah.
Okay.
Yeah,
So in answer to that one, depends how far off the outforce. It's a good thing to do, but it's not likely to dramatically change it. And I think in this, I suspect, by the way, I still think obeticholic acid is going to be the big gun. And I think these are the situations where elafibranor and seladelpar will become the go-to drugs, because they are probably less potent but probably better tolerated, would be my best guess. Men with PBC, if we're dealing with a man, are less likely to respond to URSA and more likely to need second-line therapy, okay? And are less likely to complain of symptoms, interestingly. And whether or not that's the higher level of moral fibre in men, I will leave other people to speculate, okay? Because I might get my head bitten off. One last quick one.
You got time for one more? Yeah, no, that'd be great. Would someone test positive? Why would someone test positive for AMA and ANA?
Oh, good question. Good, like they're all good questions. So there is an ANA which is characteristic of PBC. So without getting all geeky, there are different types. AMA is one thing, but ANA is lots of different things with different patterns to them. So your classic autoimmune hepatitis antibody is a diffuse staining of the nucleus, right? So that's very characteristic. There are ANA that you get in PBC that are unique to PBC. They're as specific as AMA, and they have a nuclear dot or a nuclear rim pattern. So they're very different patterns, okay? So we absolutely drive into people. The first thing you have to do if you get an ANA in anybody with autoimmune liver disease is what's the pattern? Because if the ANA is a nuclear dot or nuclear rim pattern, it's a PBC antibody. It's as diagnostic as AMA of PBC. So ANA in PBC is of two types. Most people will have that nuclear dot, nuclear rim, in which case it confirms the diagnosis of PBC and does nothing more than that. It's just an oddity, and 20% of PBC patients have it. It could, however, be a diffuse staining one, and that is suggestive of the possibility of overlap. So it's a really important question to get, and that's why I drill into them. AMA and ANA equals what is the pattern of the ANA, which then equals confirming PBC or suggesting overlap. And it's one of the tests that is most useful in determining what treatment to take.
Okay, great. Okay? Thank you.
And like all of these antibodies, once you've got it, you don't need to recheck it. You know, it's a tripwire. You've tripped it, it doesn't matter. If it goes away, you've still got PBC. If it increases, you've still got PBC, and it doesn't get any worse. If it gets lower, you've still got PBC, and it doesn't add anything. You don't need to keep rechecking it.
Great, that's great. Thank you so much for your time today. Look after yourself. I hope you're feeling better soon.
I keep saying I'll be back at some point, you know, in the future, and it always ends up being next week, actually. So, but I will be back at some point tonight. Hopefully, I will make it to Edinburgh for the next event. I appreciate I was having knee surgery, you know, for the first one, and actually, I've now discovered that these fractures in your foot are a recognised complication of having a knee replaced, because your bone, your way you walk changes after the surgery, and it puts extra pressure on the area and it snaps. So there you go. Yep. I've learned something after all these years. Okay.
we'll make sure we take a note of that.
As always, and I think we are going to constantly come back to which drug to use in which setting, because I think we are working our way through that. So we will help people as we go along. But remember, across the UK, if you are out there in the UK with non-responder bloods, you are 6 times more likely never to have had a second-line treatment than to have had a second-line treatment and it hasn't worked. Okay, 6 times more likely. So the key thing is to take something. A secondary question is, was it the right thing? And the only way we'll really start working that out is by trial and error. Okay, so doctors can sit there paralyzed by not knowing which to use when the answer is any of them is better than none of them. And it's only down the line we'll work out which one was the right one, and then we'll be able to use that information to guide people in the future.
Great.
Okay.
And any questions that weren't asked today, I'll keep a note of them for the next one. But if you need an urgent response, sorry, excuse me, please give us a call on the helpline. Okay.
And do you know what's really made me fed up today is that, as people know, I'm now known as the rock star of PBC. And actually, I'm staring at a guitar over there, and I can't get up and bring it over because of my leg. You know, it was the most wonderful opportunity. Next time. All right.
Right. Thank you very much.
Afternoon, everybody.
See you later. Bye.